Okay, so I quickly I introduce my country. So Taiwan is the most mountain dense island in the world. I think our country is very small, and there are more than higher than 3,000 meters high mountain in such a small island. There are more than 268 peaks. So as you know, we are facing a very strong country called China. Also, my university is China Medical University, but actually I study medical school in Taiwan. But Taiwan, we have we call the technology powerhouse, or we call it Silicon Shield. That we have TSMC and NVIDIA, so we can face it's kind of protection of Taiwan. So come back to my original topic. So what is SAP? So SAP is stands from the junction between the pedicle and the lamina articulate with the inferior articular pelvis of the vertebral body above, forming we call the zygophysio joint. As you can see here, this is the SAP, and it connect with the upper lamina called the IAP, and forming this facet joint. And what causes cervical foraminal stenosis? Compared to lumbar spine, I think the cervical foraminal stenosis, the anterior posterior diameter accounts more for the cervical spine stenosis compared to the cranial caudal diameter. But actually, we still need to see the anatomy of the cervical neuroforamen. So it is composed of the anterior is called the uncinate process, and we call it uncovertebral joint, like here. And posterior, it is the most important is this part. It is the superior articular process. So for this part, if the uncinate process hypertrophy or SAP hypertrophy, it compresses the nerve roots from anterior or posterior. And sometimes the disc height decrease, so the cranial pedicle and the caudal vertebral pedicle becomes near each other. That also have the cranial caudal diameter narrowing. So these four parts causing the cervical foraminal stenosis. So that's why we have different methods to create to enlarge the foramen size. So this is a Japanese study from 2017. It's published in Journal of Neurosurgery. So they study around 11 cadaver. So they check the C3 to C7 foramen for everyone. So they conduct different procedure like ACDF, or very extensive ACDF procedure like ACDF with uncovertebral joint resection, or they choose only the posterior surgery like foraminotomy, or 360 degrees anterior with posterior surgery, ACDF with foraminotomy, or very extensive ACDF, uncovertebral joint resection, and foraminotomy. So they compare, they do different procedure and to see which part can increase the foraminal size the most. So they found only one procedure, just simple one procedure, can have enough foraminal diameter enlargement. That's a foraminotomy. As you can see here, they compare the neutral and the flexion or extension position. And what we thought the most important is the extension, because when you do extension of the neck, that's a spurling side that impinge the nerve root. And they found the foraminotomy, only one procedure can increase the foramen much more than ACDF or ACDF with UVR. And even anterior with posterior, foraminotomy still become very significant. Either in neutral flexion or extension procedure can have enough cervical foramen diameter increase. So that's why, because usually we thought ACDF are the gold standard of the treatment, because every neurosurgeon, they do the ACDF surgery, because posterior surgery usually have a big wound, very dramatic muscle destruction. But recently, alongside with the MRS instrument development, so people start to focusing on the posterior surgery. So they compare how about the posterior cervical foraminotomy? Is it if you choose just only the unilateral cervical radiculopathy for the arm pain patients, They compare the PCF, we call the posterior cervical foraminal, compared to the gold standard ACDF. Is it as good as ACDF? So this is published in JAMA Neurology. This is last year in called the facet randomized control trial, published in JAMA Neurology. It's from Netherlands. It's a prospective randomized control trial. So they found if you choose the right patient, single unilateral arm pain, radiculopathy, the PCF are not only in the VAS, in the arm pain, in the neck pain, NDI, all the score is all non-inferior to ACDF. And all adverse side effects like surgical associated, all kinds of side effects, infection, dysphagia, everything, all serious like cardiopulmonary, all serious side effects, the PCF are non-inferior to ACDF. That means if you choose the right patient, the foraminotomy will be as effective as ACDF and more minimal invasive. And because we start to do the PCF, but PCF already developed for a long time. Is there only drawback of the PCF? So this is another study in 2016. So they compare, they do every patient with the PCF as initial procedure, and they use ACDF as a rescue surgery. It's a primary outcome. That means if they choose 178 patients, they do the PCF to treat the unilateral arm pain, radiculopathy, and the patient are not satisfied. They use ACDF as the rescue surgery. They use ACDF to do the final resolution. So they found, along with 178 patients in their center, they find 9 of them, they receive ACDF the rescue. Let's see what happened. So among these 9 patients, there are still disc herniation. They have still foraminal stenosis, spondylosis. It's from as acute as 3 months to 26 months. So what happened? So as you can see here, the foraminal stenosis can have different degree. Can be this is a normal foramen, and this is very minor foraminal stenosis, and this is moderate, and this is very severe foraminal stenosis. So so when you do foraminal decompression, maybe when you face the like this moderate, this is very severe, some stenosis coming from the ventral side. When you do from posterior, the ventral side will be very difficult to decompression, or very narrowing, you feel very afraid you do the decompression. That has some not enough insufficient decompression. And also I found along my clinical experience and along with the article reviewing, I found not only the residual pain, not only the wound infection weakness, there's a very common side effect among all the PCF surgery. As you can see here, no matter non-revision or ACDA revision, among all the 178 patients in that review, they are around 30% of the patient, they have the numbness or tingling after the surgery. So that means they have dysesthesia after the surgery. So I want to raise, if we want to develop the PCF surgery, like posterior cervical foraminotomy using endoscope, I think there are 2 problems I need to solve. The first, do we have insufficient foraminal decompression, and how to standardize my PECF procedure? And the second is, I think there is inevitable postoperative dysesthesia, and why is the reason causing this dysesthesia? Does the approach method matters? So this is the 2 problems I want to raise. So the first, we come to the basic. The basic is what's anatomy of the ligamentum flamen. So for cervical spine, we call the yellow ligament is very different from the lumbar segment. As you can see here, so the yellow ligament is like a butterfly and skipping in different segments. So it's not continuous. And the yellow ligament in the cervical spine, which is very different from lumbar spine, is it only stay in the central area. So as you can circle the foramen sides over here, and you make the circle a 4 quadrant, 1, 2, 3, 4, and the nerve roots come from the third and go outside of the foramen to your arm. And as you can see, the third part, this is the most important where the nerve roots goes. There's no yellow ligament here. So this is a very important anatomy. So since there's no yellow ligament, when you do the foraminotomy, you are inevitable facing the nerve root itself. There's no yellow ligament protecting the nerve root. So here I want to provide my concept of how I do my PECF procedure. So this is a drawing that I draw by myself. So this is the cranial size of pedicle, and this is the caudal size of the pedicle, and this is the SAP, and this is the red line is I already removing the shingling, the IAP. As you can see, the blue line is the nerve roots just under the SAP. So I want to show everyone because there's no yellow ligament over here. So I want to do the first step is to partial caudal pediculotomy. I will show in the video. The first part I will exposing the caudal pedicle and do partial pediculotomy. And I will thin this SAP. I made a gutter over here and over here. And I do a cranial lateral gutter development. And I will do a en bloc medial SAP resection to remove this SAP whole piece away. I don't want to piecemeal repeating cutting the SAP in order to touch the nerve root inevitably, causing the postoperative dysaesthesia. So this is my method. I call it partial pediculotomy and en bloc medial SAP resection. And through this method, it not only reduce the postoperative dysaesthesia, I can also see the pedicle as a landmark. So people always ask me, so how do you make enough decompression? I tell them the medial side and the lateral margin of the pedicle is your important landmark because outside of the pedicle, there's nothing ventral side. So there's no disc will compress the nerve roots. I will show you in the MRI later. So this is my the intraoperative video. As you can see, this is C5, this is C6, so this is cranial, this is caudal, and this is the V point where we start the PECF, and this is the shingling IAP. I will remove using the bird to remove the IAP and showing this is the pedicle and this is the SAP. And I will along this line to break the SAP and take the whole piece of SAP away. And along here, as you can see, this is the nerve root. So as you can see, you do one piece away, there's no yellow ligament under, so you don't need to piecemeal to cut the SAP, so to reduce inevitable touching the nerve roots. And later you can decompress the nerve roots until this medial part to lateral parts of the pedicle, so that's a fully decompression. So I also show this photo. As you can see, this is the already do the decompression, and this is the pedicle. So this is the medial side, and this is the lateral side of the pedicle. So through this decompression, the nerve roots are fully decompression from medial to lateral. And from cranial to caudal, you also meet the cranial pedicle to the caudal pedicle. So no matter in different decompression, you not only decompression medial to lateral, but also cranial to caudally. So let's see how I do it. The first I will find the V point and I will make a landmark where I start. And I use the bird to create, to remove the shingling IAP. And this is the SAP. And this is the shingling IAP. So you have to remove the shingling IAP to exposing the whole piece, the SAP, and curate, take off the cartilage in between the facet joint. And then you made a gutter along here and then along the laterally, and then this part of the SAP is what you design, you want to remove, this medial SAP. Then you break it and take the whole piece away. And then you piecemeal remove the residue part, then the nerve root is fully decompressed. So this is what I want to show you, why the lateral border of the pedicle is very important. As you can see the MRI, so this level, if the disc herniation is over, this is the foraminal HIVD. This is what's the most best indication for foraminotomy, for PECF. As you can see the disc herniation over here, and the lateral margin of the disc of the pedicle is here. There's nothing in the ventral side, only the vertebral artery. So you decompress to the lateral margin of the pedicle, that's enough. So that's why that's what I want to resect. So I will do the CT scan preoperatively. As you can see here, I will draw a line to plan what is the SAP I want to resect. I draw a line along the lateral margin of the vertebral body. Usually it's in the middle line of the vertebral artery foramen, the vertebral foramen. And then I calculate from the facet joint, the most medial side. I cut this triangle. This is where the SAP I want to resect. I plan this before operation. And after I decompression this, the foramen will fully decompress. And what's important is where the pedicle is. So let's see here. So I call this medial SAP resection. So majorly is this part, the red part, because the nerve root goes here and outside of the pedicle, there's nothing ventrally. So you cut this part to decompress. And what's important is the pedicle is the most important. So we come back to this circular, the quadrant 1, 2, 3, 4. The quadrant 3 is very near the pedicle. So when you open the foramen, the V point, when you open, when you see there's no yellow ligament, that means you are very near to the pedicle. That means you are very near to the pedicle. So you start drilling the pedicle. So you can find the pedicle. You find the cortical bone after you drilling all the cancerous bone, you find the cortical bone again. That means you go into the pedicle. So that means you are along with where you start your en bloc. So you can drill in the gutter and remove it. So let's see how I find the pedicle. So first is the V point. You remove the shingling IAPA, you found the pedicle is cortical bone inside the cancerous bone. So this is where the pedicle is here. So you start cutting with one piece, like here. You remove the medial where you design, you want to remove this medial SAP, and you use the curette to lift the SAP and take the whole piece of the SAP, like this one. You take the whole piece of SAP, you take it away, and you found there's a nerve root just over here. And if you want to do a little bit more, you along with the pedicle, you remove, this is, as you can see, I show you where this is the pedicle. This is the pedicle. And from medial to lateral pedicle, the nerve root will be fully decompressed. You see, beautiful, this is where the pedicle is. And you decompress from medial to lateral, then the nerve root is fully decompressed. So I show you what happened after I follow up the MRI. This is preoperative. As you can see, right side compared to the left side, the foramen is very stenosis. So after decompress, you see I cut 50% of the SAP over here. And the foramen becomes very widening. And the nerve root is over here. It's fully decompressed. And the residue of the facet joint is only 50% of the SAP resect. Almost IAP is almost totally over here. So the stability is very good. So if you want to do more extensive, you need to understand the nerve and disc anatomy. So as you can see this anatomy study, you see C4-5 is the most important, the most dangerous part, because the disc is just anterior to the nerve root. Above the C4-5 is on the shoulder side. Below C45 is on the axillary side, and more lower the disc doesn't touch the nerve root, it's more safe. So when you do C45, you have to use my En Bloc SAP resection, because if you piecemeal remove, like some traditional doctor, they piecemeal remove here, they are touching the nerve roots, causing the postoperative C5 palsy. So you have to use my method. You have to find here and drill in the pedicle and find the axillary side, and you do the En Bloc SAP away. So you can not only decompress medial to lateral, you also decompress cranial to caudally. So I show you this one. This is the HIVD. I already removed half of the pedicle, and the nerve root is pushing here. When you do partial pediculotomy, you have the space to work, move your scope, go over here, and so you can remove the disc safely without traction of the nerve root. You don't traction the nerve root. Our neurosurgeon, we don't want to traction the neural structure. So you don't traction, you just remove the disc gently. And then finally, after you remove the unhealthy bulging disc, you find the nerve root come back to the original place. Very beautiful. Inflamed nerve root become round, not flat, go back to its original place. So this is called the partial pediculotomy, partial vertebrectomy approach. You go under and remove the pedicle, go to the vertebra, so you can remove the disc without traction the nerve root, without traction of the nerve root, without traction of the nerve root. This is the most important, because you cannot promise every time you traction the nerve roots, patient have some deficits immediately after the surgery. Maybe they recover, but they still have the symptoms. So this is how I do partial pedicular and the partial vertebra. As you can see here, I can go down to the body. So the nerve root should be here. I go down to the body, I remove the disc safely. So I can approach finally the cranial and to caudal pedicle. The foramen is very wide right now. So as you can see here, most of the time, the facet joint is only 50%, less than 50% resection. The stability is okay. Using the endoscope compared to the microscope, you can see the nerve root very beautiful. As you can see, you always should see two roots. One is sensory, one is motor. Sensory over here, motor over here. Two roots, very beautiful. You remove the disc from the axillary sides. It's very safe. And you can do two level sliding technique. You do C4-5, one incision. You just slide, because cervical lateral mass is only 1 centimeter diameter. So you just slide a little bit. You can go to the lower level. You remove with one incision. Two level, easy. So from here, I provide my first concept. I suggest everybody learn partial pediculotomy and the medial, maybe half SAPT resection. You have to practice because not every case is simple disc herniation or simple stenosis. For moderate or severe foraminal stenosis, you have to learn this, and you have to standardize the procedure to make sure sufficient decompression. And the one piece remove the SAP tip may decrease the repeated maneuver over the nerve root, decrease postoperative dysaesthesia. And the pediculotomy can additionally increase the cranial caudal foraminal size. And this is my patient demography. Some of the patients I do the postoperative CT scan because my country's insurance doesn't cover everyone has postoperative CT scan. So I calculate my patient 70 level. So they are in different levels, and the result is very promising. The arm pain before surgery is 7, and after it becomes less than 1. And I want to raise my second topic. So I want to compare what's called the incline and the lateral mass PE-SAP technique. As you can see the drawing here. So for the landing point, some of them are landing in the central. So my endoscope is just beside the central spinous process. And the other is the lateral mass approach is 1 centimeter away. I duck in directly on the V point. As you can see here, central is just beside the spinous process, and the lateral mass is more lateral, ducking over the facet joint. So what's the difference? As you can see here, if you do central, you are more inclined. So you want to preserve more facet joint. And the lateral mass, you just resect the facet joint. So you receive more facet joint. So you don't need to incline. So I want to compare two methods. So which is best? For this one, I think I guess the foramen size will increase more. For this one, I want to see if I can preserve more facet joint, but still have enough decompression. And for this one, because facet joint will resect more, does it harm the postoperative stability? I want to see. So this is the method sometimes I forget. So I check the postoperative CT scan. So for this surgical foraminal approaching angle, if this is negative, I call this incline methods. If this is like this one, more positive, receive more facet, I call this direct lateral mass approach. So the first, for the central approach, for the incline approach, the facet resection is much less. For the direct lateral mass approach is significant, of course. How about the medial foramen diameter increasing rate? As you can see, the incline approach, the foramen diameter is much less than the direct lateral mass approach, but still enough. For the distal foramen, I think both way has less than the medial diameter increase, but the direct lateral mass approach is still significantly higher than the central approach. So this is the sum up. So for the central approach, incline approach, the facet resection rate is much less. The medial foramen diameter and the distal diameter is less than the direct lateral mass approach. In contrast, that means the lateral mass approach can have much more medial and the distal diameter increase. However, although the incline has less foraminal diameter increase, the both group, the patient have satisfied the arm pain decreasement. As you can see, both group, they both are very satisfied. Also, the central is a little bit higher, is not significant. How about the stability? Also, the direct lateral mass approach receive more facet. The stability in lordosis and kyphosis are either very good, and even they are original kyphosis, both group, they become lordosis again. So let's see the patient. So this is a C45, very stenosis. I do the direct lateral mass approach. As you can see, the foramen, I reset a huge foramen. So maybe some people will say, oh, the facet joint resect too much. So the facet joint will eat stability, but the patient has very severe inflammation of the nerve roots. I do the very enough decompression and see the patient result. So I asked them to do first the arm. So there's no any motor deficits. And I also asked the patient to do the neck motion. So as the patient does have the neck pain or sore, he said nothing happened. So the second patient pre-operated already C5 palsy. I have to do very severe stenosis. I have to do very extensive direct lateral mass decompression. As you can see, 2 level, very extensive decompression. How about the patient? After 6 months, the C5 palsy almost totally recovered. As you can see, his right arm originally is totally C5 palsy. After the surgery, he is satisfied, recovered. And the neck pain, no need the neck collar, no need any additional fixation surgery. And this patient, she received the preoperated ADR, but the facet joint is fused. So I resect almost 100% of the facet joint, as you can see here. Almost all the facet joint decompress. Let's see the patient. The patient, I check her stability. He said initially a little bit facet refer pain, interscapular pain. He said around 2 months he has a neck sore, so I asked her to wear the neck collar. And after 2 months, he said no pain anymore, and the neck stability motion is very good. And the arm pain totally recovered. No arm pain anymore. So she received the ADR, not improved. I need to do the PECF to rescue his arm pain. So my result is pretty satisfied. So I will suggest my method is very safe. How about central and incline method? I found the stability is the same. Foraminal diameter, also the dilator mass has widening resection, but also provide widening foraminal decompression. Stability is good. However, I found something interesting. The postoperative dysaesthesia numbness central is much higher than the dilator mass approach. So I provide a theory here. The lateral mass approach, because you direct coming here, your Kellyson punch foot plates are inevitable. Central approach is inclined, so it's inevitable touching the nerve root. So you have to use the lateral mass approach because it's horizontal to the nerve root. You will not touch the nerve root. So my conclusion is PECF is safe and effective surgical method to treat the unilateral radiculopathy, and combine my partial pediculotomy and the en bloc medial SAP resection can prevent the segmental paralysis, C5 palsy, and the numbness after the surgery, dysaesthesia. And incline method also it can reduce the facet joint resection, and also can create adequate foraminal decompression, but may cause postoperative dysaesthesia due to the inclined inevitable touching the nerve roots. So that's my conclusion. So this is my I joined the workshop. I'm an instructor there this year. So this is the workshop in İzmir, and I have wonderful experience during my tour in Efes. This is very wonderful, very historical place. And I thank to my PSLD godfather, Dr. Lincoln Tech. And this is the workshop in Taiwan last year. And we will have the second PSLD base camp and welcome everybody to join in this September. And this is our workshop. We have very like the real surgical place. Every instrument is like a real, and we have the scrap nurse to help each other. So I'm looking forward for everyone to join our workshop. Thank you.
Thank you very much, Dr. Lu, for the presentation. It was very insightful. For now, I don't really have any questions, but if we have any questions, you can write it in the chat and I could read them. Let's give a few minutes for the questions if we have any. You can also write not only the questions, but any remarks that you would like to make about the presentation and the topic in the chat as well. For now, we have only one, and that is from Dr. Ramazan Özdemir. Thank you, Professor, for the good presentation. Let's see. And another one from, I think, Selin Özda. Oh, we have one question from Yilin Yu. I don't know if that's the name, but they're asking if this is a self-paid surgery. So if this is like, you know, optional surgery that you pay, you cover the costs yourself or not.
Yeah, it's in my country because when we use endoscope, so the government, the National Health Institute, they don't cover the surgical fee, but they cover the admission fee, the nurse fee, the anesthesia fee, the material, but they don't cover the surgical fee and the endoscope like bipolar irrigation tube. They don't cover this.
Okay. I think that it also really depends on the country. It changed from one country another. I think in some countries it could even be covered by, like, the all costs could be covered. But yeah. So as far as I can see, we don't have any more questions or any more remarks in the chat. Okay, actually you have one more question, but I think you can, okay, the question is how much approximately does it cost in Dr. Lu's center? I do have some patients who are very much interested. It's optional if you would like to answer or not.
So in my country, in my institute, I think we don't have a uniform cost for different institute. But in my institute, I personally define the prices of around 5,000 US dollar totally for the all the cost. So majorly is for the endoscope bipolar, and because in my place also we have our own endoscope. We also to borrow the endoscope from the company, so we will have to buy the bipolar. So also I I use the irrigation tube, and I don't know if you guys use the flow seal after the surgery. So for the lumbar spine, I will use the hemostasis agent, because I will ask the patient to buy it because that can reduce my chance to put a drain. And for cervical spine, or I use it, but I still put the drain because it's a cervical spine. I don't want the patient have the chance to have an epidural hematoma after surgery because it's a minimal invasive surgery. It's a high-end surgery. I want every patient very satisfied. No need to have drain, no risk of any post-operative complication. So totally it's around 5,000 US dollar.
Okay, thank you very much. We have one more question from Chen Hua. Amazing speech. Thank you, Professor Lu. Is it necessary to remove peridural membrane or fibrotic tissue around the root?
I thank Chen Hua. Actually, Chen Hua is my classmate. He's my classmate. Thank you for joining this. Chen Hua is a wonderful endoscope surgeon in Taiwan also, and he has a very experience. He also have another specialty is ultrasound guide endoscope surgery. So I would suggest you to have him to have he has published article about the endoscope guide to do the anterior cervical endoscope surgery. He has he developed a method. We developed a method like using ultrasound to insert the endoscope to anterior of the cervical. That can reduce the chance of the carotid artery and the esophagus damage. So I think Chen Hua, he asked about do we need to remove the peridural membrane? I think that membrane initially we don't know what it is because it is not ear ligament. And sometimes when the very narrowed foramen we see it's very, it's like a very thick membrane. So finally, I understand it's a suspension ligament. You know, all the nerve root, they have suspension ligaments surrounding the nerve root to help hold the nerve root. But when it flants a lot, this suspension become very thick. They want to help stabilize the nerve root, stabilize the facet joint. So it becomes a pathology that strangulate the nerve root. So, but initially when I start to do the PECF, I will remove every suspension ligament to release the nerve root, like what I showed the photo of the nerve root you see clearly. And gradually I found the pathology should be the SAP. So the bony structure should be like a lumbar spine, the yellow ligament should be the pathology. The lumbar yellow ligament you remove, you don't need to remove the membrane in the lumbar spine, in the lumbar root or thecal sac. For cervical also, I think when you remove the SAP, the suspension ligament can also preserve the stability. And after you remove the SAP, gradually it will become thinner after the surgery. So right now I don't remove, because when you remove, you spend around 20 more minutes because you remove and there are copious capillary bleeding over there. You have to stop the bleeding. You just waste your time and just gain a little bit. And you do stop bleeding, you do the bipolar, so you will have some coagulation over the nerve root, so you create more thermal injury. So I just don't want to do it anymore.
Okay, thank you very much. We have one more question. Amazing talk, Professor Liu. Here's my question. Would you use osteotome to remove part of pedicle or SAP, or just using burr or Carrison punch?
I think it depends on what you have uh, in your operation theater. And for what I have is only the burr, the Carrison punch, and because I am neurosurgeon, I am more familiar with Carrison punch. I used Carrison punch when I was a resident doctor, so I will use the Carrison punch. But the thing is, when you use the Carrison punch, you need to have the smallest one. That's called the 1 millimeter Carrison punch. Because when I show the En Bloc SAP resection, you have to go to the cranial pedicle after you do the partial capitulotomy. You have to use Carrison to break the gutter you create. So in that situation, you need to go under the SAP. So I need the smallest SAP to remove it. And I think using osteotome is familiar with orthopedic doctor. And I think osteotome is very nice because if you use the osteotome, you don't need to break the SAP using the Carrison punch. So you become no punch technique. Like in Taiwan, we have Professor Pao. He doing the lumbar surgery, he used Carrison punch. So he do the no punch technique. So he chisel the SAP tip and take the SAP away. So I think if I am a unipotal doctor, so if I can use the if I unipotal, if I have an osteotome inside my unipotal, I can chisel the SAP so I can take it away. But right now I just don't have the osteotome. But if I have osteotome, I will definitely use it. I think it's a very nice way to remove SAP without touching the nerve root.
Okay. We have one more comment from Dr. Shanhua. Thank you very much, Professor Liu. If we don't have any other questions, I myself actually have one more question. So my question is rather about the patient outcomes. It's just, have you noticed any like major differences in patient reported cases like the pain or the function between the patients that were treated with SAP En Bloc Resection and those who had traditional foraminotomy?
Oh, thanks, the moderator. So can you describe the question again for the?
Sure. So basically, in the patients, there are like the patients that probably had the traditional foraminotomy and then the ones treated with the SAP En Bloc. Were there any major differences between the function, I don't know, the pain and how the patients recovered afterwards? Since it's minimally invasive, I think this is like a better procedure, but I'm not really sure.
Oh, you mean compared to the like a tubular MIS, PECF, and PECF endoscope surgery, right? I think definitely. I think endoscope cervical spine surgery will be the best because cervical spine is a very it's a very small part of the spine. So it's a very beautiful organ and a gentle organ over here. So the vertebral body, the facet joint are very small. So if you use the traditional tubular way to do the foraminotomy, you are inevitable have at least 2 to 3 centimeter. You have to, because deep, so you have to create a corridor to allow your microscope to see inside. So you have to have 2 or 3 centimeter of the wound to go inside. So that will destroy the muscle structure behind. So for here, for cervical, what's the stability? Why, when I do the foraminotomy, I do the wide resection, why my patient's stability is still very good? Because I preserve all the muscle. So the muscle is intact, no damage. So when you reset the facet joint, so the muscle is protecting the stability. So if the lordosis is keeping the muscle, help keeping the lordosis, so the stability is good. And after several months, you know, when you do foraminotomy, you resect the bony surface. The bony surface will regrow with callus and regrow with the stem cell, regrow the bone. So I have several patients I follow in 3 to 5 years. I see the foramen become I create the foramen become smaller after several years. That's why, because the bone regrow, remodeling. But the patient have no symptoms, no arm pain again, and nor instability problem. So I think what's most treasure part of the endoscope is preserve the muscle. I think the PCF is already very beautiful, but endoscope PCF can preserve more muscle. That's why we use endoscope. I always describe the endoscope for cervical spine uniportal is like a match. It's like a marriage. It's like a husband and a wife because the size is just the same. Uniportal endoscope for cervical spine. It's just the size is okay. It's perfect for this small endoscope to do the small pathology and destroy just a little bit. So I think it's good match.
Thank you very much. I think we don't have any more questions or any more regards in the chat. With that being said, I see that we have a distinguished guest from Ukraine joining us today as well. Dr. Sergey Balan, if you are still online, would you like to add anything or ask a question?
Selin, can you turn on the Sergey Balan's microphone, please?
I couldn't find his name. Can you help me? I found.
Okay. Yeah, the microphone.
I sent request, Dr. Sergey Balan.
Connect. Can you hear me?
Yes, we can.
Oh, thank you very much for the best presentation. I was in Professor Lim in Seoul, and I studied this method, but I cannot try it because I don't have in my country special electrode. Thank you very much. I promise that I will start to use this method after your presentation.
Thank you. Thank you.
I understand all of this thing, and thank you very much one more.
Thank you. Thank you. Thank you.
Thank you, Dr. Balan. And once again, thank you, Dr. Lu. It looks like there are no more questions in the chat and also no more regards. So once again, thank you for the presentation, for sharing your knowledge and experience with us. I'll now hand the things over to Professor Suju for some closing remarks.
I want to thank Alex, and I want to thank everyone who joined us today, Sergey, Balan, and others. I hope we meet in a short time in Taiwan or in Turkey again. We will be very happy to meet you in İzmir again.
Thank you.
Thank you so much.
Thank you.
Okay, Selin.
Thank
You
you for everyone. I will close the session. Have a nice weekend.